I would like to invite Professor Gopal Pillai, Head of Department Experience with Broluzicumab.
As we know, we have all completely moved towards intravitreal injections only now that photodynamic therapy is not available. So PCV is one condition in which now we have to treat with injections, and we do not have PCV. We have one particular thing in our hands, that is focal laser to the polyps. But other than that, we do not have PCV, and we have to treat them with injections. And the ongoing challenge always, as always in neovascular AMD as well as PCV, is to treat of injections. So it's like if you give 12 injections in a year, it's really good for the visual acuity, but for the patient as well as for the surgeon, it gets really tight if you're giving that many injections. So how to reduce the number of injections and at the same time maintain treatment efficacy? So we should go into the newer pharmacology. It's like, what is a single chain antibody fragment? So that's a autonomous binding agent that no longer dependent on heavy molecular, FC chains or FL chains. That is not required. And so they are very, very small molecules which can penetrate easily, and their molar concentrations are quite high. So that is a single chain antibody fragment as opposed to a complete antibody which we have been using so far. So that's the drug in a single injection, because the molecule is so small. More potent inhibition of VEGF-A. In which there is a type 1 choroidal neovascular membrane or a large pigment epithelial detachment, it can go deep into the choroid. A comparison between the available molecules right now, aflibercept, ranibizumab, bevacizumab, and broluzicumab, you can see that the molecular weight is only 26. Number of molecules per injection, or the molar concentration, is almost 25 times that of bevacizumab. Good. A single thing which is there, and it penetrated the retina more rapidly in preclinical studies. So having said all that, now let us come to some real world scenarios. Now this is I have about 6 or 7 cases. So this is about presented in May with CNVM with subretinal hemorrhage. There were 6 injections of bevacizumab which was received and referred, and the patient's vision was 6/60. And this is the subretinal hemorrhage on presentation. You can see the leakage of that polyp there. And previously received 6 intravitreal bevacizumab injection, but then had lost a follow-up and then had a subretinal hemorrhage, came back with the hemorrhage, and after 1 dose of broluzicumab, and we did a focal laser to that peripheral, near the arcade, we did a focal laser to that polyp, and then you can see that even though the central macula remains almost the same, the vision improved to 6/36. Now let's go to case number 2. There was a suspected exudative retinal epithelial detachment. You can see the large pigment epithelial detachment on the fluorescent angiography, and just nasal to the large pigment epithelial detachment. This is the autofluorescence, which shows the large pigment epithelial detachment here and some damage right in the center of the macula. And these are the OCTs in the, from February, March, and then in August. You can see that after a couple of injections, the pigment epithelial detachment is very large. It just fell down and fell down flat. Something which we had not seen in the bevacizumab era or even the ranibizumab era. We had not seen that. With aflibercept, we had seen such a thing, but this drop in pigment epithelial detachment is more consistent here. And this is by November. Patient's vision has improved to almost 6/6 parts. Now, case number 3. Here is a submacular bleed, which is like a fresh bleed as well as an old bleed, and there is a polyp on ICG and late leakage on indeterminate source on fluorescent angiogram. You can see the polyps here, and you can see that follow-up on ranibizumab, October 2021, February 2022, June 2022. No significant reduction in the hemorrhage or in the improvement in vision. And then we gave a broluzicumab there, and you can see the flattening of the pigment. This is a large pigment epithelial detachment, which completely almost flattened, and vision improved to 6/9 with focal laser as well. This is again a 63-year-old eye with CNVM with a submacular bleed with intravitreal implantation of broluzumab in April. You can see the polyps right here, just on top of the, just here. And you can see the, pre-injection 6/12 and 6/9 vision it improved to. And finally, we had planned a focal laser, which needed not to be done because there is no fluid over the last so many months. So this is again another case in which there is a lot of large pigment epithelial detachment and a subretinal bleed. You can see the post-injection visual acuity is 6/12 here, and then it improved to 6/6. So this is case 6, very huge, tall peak. Using broluzicumab in switch patients from ranibizumab or from bevacizumab or something like that, and almost all of them improved. Long-term stability, maximum efficacy, and duration. Duration is a very, very important key thing, because many of these patients with broluzicumab, after one dose, you do not require a second injection for maybe some time. So one patient had inflammation after the second injection, managed with topical steroids. So the Indian data so far is about 18,000 injections and about 100 cases of intravitreal inflammation, which puts it at 0.005. So this is to summary. So broluzicumab in clinical trials is non-inferior to aflibercept. Long-term maintenance and control on retinal thickness fluctuations can be there, and a lot of patients are on 3-monthly dosages. Welcome all of you to Kochi, 11th to 14th May for the Mega AIOC 2023. Thank you very much.
Thank you, sir, for sharing those interesting and impressive